As we get settled, I'll remind everyone to please turn off their cell phones. Good evening. I'm Tracy Ferguson, the president of the Avonworth Historical Society. Our board of directors and I finally wish those of you here and those watching by live stream a warm welcome to the 2020, 2021, and 2022 Joint Historical Society Lecture. We also want to thank the Community Presbyterian Church of Ben Avon for allowing us to use this beautiful sanctuary to gather in friendship and listen to our esteemed guest speaker this evening. Since we all are interested in history, we decided to hand out a brief early history of the church. You will see that there is a link to the church website at the end. This link, cpcba.org, will take you to a full history of the church. After 2 long years of planning and delaying this lecture, we are pleased to be here tonight. These past 2 years have truly been a trial for the mind, body, and spirit, and I would like to pause for just a moment of reflection. Will you join me? Thank you. And now it is my great pleasure to introduce our guest speaker for this evening. A graduate of the University of Pittsburgh School of Medicine in 1978 and an internship in surgery at Johns Hopkins Hospital, Dr. George Magovern Jr. is a board-certified thoracic surgeon. He is the Emeritus Chair of the Allegheny Health Network Cardiovascular Institute, System Chairman of Allegheny Health Network's Department of Thoracic and Cardiovascular Surgery, and Professor of Surgery at Drexel University College of Medicine. He began his practice in 1985 at Allegheny General. In 1992, he performed Allegheny's first single lung transplant. In 1998, Dr. Magovern formed one of the first departments of thoracic and cardiovascular surgery in the United States. In 2012, he was appointed to the board of directors for the American Board of Thoracic Surgery. His expertise, credentials, and accolades are numerous and outstanding. And I know that either this Dr. George Magovern or his late father, also Dr. George Magovern, have touched the lives of many of you or a loved one or friend over their impressive careers. Please join me with a warm welcome for Dr. George Magovern Jr.
Well, thank you, Tracy, for such a nice introduction, and it's certainly an honor to be able to be speaking to the Avonworth Historical Society, which, as I learned from the slide, represents Sewickley, Coraopolis, Moon Township, as well as Emsworth and Ben Avon. So that's a good representation of historical societies. And there have been many physicians who have lived in Ben Avon, as well as these other communities over the years who've worked at Allegheny General. Probably the most famous physician in Ben Avon history is a physician by the name of Dr. Chevalier Jackson. And he was born in 1865 and grew up in Pittsburgh, went to medical school, went to college at the University of Pittsburgh, went to college or medical school at Jefferson, came back to Pittsburgh and worked at Allegheny and lived in Ben Avon. And he's considered the father of what we call bronchoscopy and esophagoscopy. And so at the turn of the century, he developed tubes, which would literally be metal tubes, and probably the size, in some cases, of a garden hose. And he was able to pass them through the mouth or through the nose into the airway and into the esophagus. And at the time, there were many children who were ingesting, say, coins, and they would swallow it, and it would get stuck either in the airway or in the esophagus, and they had to be manually extracted. And up until Dr. Jackson developed these bronchoscopes and esophagoscopes, there was no treatment for it, and many of the patients would pass away, either because it obstructed the airway or the coin or whatever. The other types of objects that would be swallowed would be safety pins, baby pins, fish bones, chicken bones, and mentally ill people tend to ingest needles for some reason. So that type of thing would present. And if they're not removed right away, they'll actually make their way out of the esophagus or out of the airway into other organs, which could also be fatal. So he performed in his career 2,000 of these procedures and is considered the father of that. His museum is actually in Philadelphia. The other physician that I remember early as a child working at Allegheny and practicing was a fellow named Dr. Brainerd Hawk, who I think lived on Irwin Avenue, and he was an obstetrician. So he delivered all of my sisters, not my brother and I. We were born in New York City, and had a big practice. And he was a very colorful obstetrician as well. In those days, you know, nobody worked as a team. The obstetricians all had their own practices, so they were on call 24/7, and he was known for being in the hospital for days at a time, delivering all sorts of children from all over the city. But in any event, we'll start with the first slide. I thought I would talk about heart disease at Allegheny General, which really has its start in the 1950s. And really up until the late 1960s, the treatment of someone who had a heart attack or had heart disease was simply bed rest, examination by the physician with a stethoscope, and a tincture of thyme. I was watching a show last night on PBS, and it takes place in England in the 1960s, and one of the actresses, or actually it was a nun in the show, had a heart attack, 1962, and they brought her to the hospital and had bed rest, a stethoscope, and a tincture of thyme. There was no invasive monitoring or any type of catheterization type procedures. So, next slide. The really beginnings of the surgical treatment of heart disease begin in 1953 with the heart-lung machine developed by Dr. John Gibbon in Philadelphia at Jefferson Medical Center. Next slide. And this is his name, and for some reason he wasn't able to capitalize it on his own invention, and his results using the heart-lung machine that he invented were really not satisfactory. Next slide. But the earliest hospitals having a good bit of success with heart surgery included Johns Hopkins, University of Minnesota, and then Methodist Hospital in Houston, Texas. And some of these names I'm sure are familiar to you. Certainly Dr. Cooley and Dr. DeBakey had a long-standing feud in Texas about who was the better heart surgeon and that sort of thing. Dr. Lilly High at the University of Minnesota actually did a procedure where he would use the mother or the father as the heart-lung machine. So the baby would need corrective surgery on the heart. So the baby would be in one bed and the mother or father in a bed next to the child, and they had cannulas going back and forth so that the baby's circulation would be supported by the parents. And he did 100 of these procedures in the 1950s without a mortality. I mean, it's still a breathtaking record amongst surgeons to this day, because, you know, as most of the surgeons quickly surmised, the operative mortality of that operation is 200% if you end up having trouble with both the parent and the child. Next slide. And here's a picture of Dr. DeBakey in the late 1950s in Time magazine. These surgeons were larger than life, received a lot of publicity. And next slide. But in Pittsburgh, Dr. Kent was doing some of the similar work at Allegheny General in the 1950s. He was a very reserved, quiet fellow, but a very capable surgeon. Next slide. And was considered a very technically proficient surgeon in Pittsburgh. He was the head of thoracic surgery at Allegheny, but Allegheny at that time was part of UPMC, so the residency program for thoracic surgery was at Allegheny, but it was part of the university. Next slide. So 1958, this is an actual operative tablet of patients undergoing open heart procedures. So this is January of 1958 until the end of June 1958. And if you can see, most of the patients are relatively young. They're in their 30s, equal distribution of men and women. And then you can see that they also look at time on the heart-lung machine, or what they call time on the pump. And if the time on the pump exceeded a half hour, for the most part, the patients did not survive the surgery. And then in the next slide, you'll see the results from July through December. And it's interesting from my standpoint, because at this point I was 4 or 5 years of age, so I had some understanding of what was going on with my father. He would typically prepare for the surgery with Dr. Kent on Mondays. They would prime the heart-lung machine and then do the operation on Tuesday. And then he would stay in the hospital with the patient Tuesday night, Wednesday night, Thursday, as long as it took to either have the patient recover or pass away. But occasionally, he would come home on Tuesday because, as my mother used to say, George, you have to be on your best behavior tonight because the patient your dad operated on died on the table. We all knew that meant we better get upstairs and do our homework and stay out of the way. So you can see that a number of these patients died on the table. Next slide. So for that year, there were a total of 40 patients who underwent surgery with a mortality rate of 42%, which is awfully high, and took a huge toll both on Dr. Kent and my father. And there were surgeons who were practicing in other fields who would come into the operating room and accuse Dr. Kent or my father of doing warm autopsies, which was a pretty tough thing to say to the two of them. But knowing the two of them and knowing in particular my father, that just gave them more determination to prove them wrong. So go ahead. So this is the, again, a slide of the patients having surgery. And you can see that most of them had rheumatic fever, and the diagnosis was either a problem with the aortic valve or with the mitral valve. Those are the two valves in the heart that were most often affected by rheumatic fever. So if the rheumatic fever attacked the heart valve, then it would either be blocked or leaking or both. The whole concept of doing bypass surgery didn't come about for another 10 or 15 years. Okay, so this is a picture of my family in 1958. So it's my brother and I and three of my sisters. We're all taking a bath together, and that's one picture I think I'm getting my first Holy Communion or whatever. But it just shows you that we were pretty much a normal growing family, and my father was taking on a particularly difficult pioneering effort. And I'll have to say he was pretty good about it. I mean, he didn't come home angry or frustrated. I mean, he was pretty gracious about what was going on in the hospital. All right. So as I mentioned, Dr. Kent trained the residents in thoracic surgery for the city of Pittsburgh at Allegheny, and he refers to Pitt at the time as the University of Pittsburgh Medical Center, which is 30 years before the university renamed itself UPMC. So he was again ahead of his time. the residents who worked in thoracic surgery through the 1950s and 60s made $175 a month. The average salary of a person working in the 1950s was somewhere between $3,000 and $4,000. So they were making maybe $1,000 a year, which was not enough to really live or buy a car. Dr. Kent went on to be president of an organization called the American Association for Thoracic Surgery, which is our most prestigious national, international organization. And that's quite an honor. In Pittsburgh, my father was president of a similar organization called the Society of Thoracic Surgeons, but the American Association for Thoracic Surgery at the time was the only organization in existence. Go ahead, next slide. And this is a picture of Dr. Cooley doing a heart transplant in the late 1960s. And when Dr. Kent was named president of the AATS, the meeting was held in Pittsburgh. And I remember there was a cocktail party at my father's house in Fox Chapel. And we all had a chance to meet Dr. Cooley, Dr. DeBakey, Dr. Lillihei, and all these famous surgeons from around the world. Next slide. So at the time, here I am in high school. My dad bought me a Checkered Cab to get back and forth from Shadyside Academy. I wanted a car. He said, well, sure, we'll get you a car. So I had mine on a Corvette or some type of sports car. But we ended up with a green Checkered Cab. And that's my youngest sister, Ann, who at the time was 1 or 2 years of age, and my brother, Jim. All right, next slide. So Dr. Kent, as head of the residency, had to write letters describing the status of a resident finishing the program. You know, how strong were they academically, how strong were they clinically. And so the next slide, this is a letter that he's writing about a Dr. Rattan in 1962. And the next slide, in large type, describes Dr. Kent's feeling of this fella. So Dr. R, as a surgeon, is a complete loss. He has no interest in patient care. He's lazy. He will never contribute anything to the welfare of his countrymen or anyone else. So that shows you, the temperament of Dr. Kent. And I think it's also typical of that post-World War II generation of men. They were not particularly politically correct. I mean, they basically stated what they thought was the truth, and whether you liked it or not, that was your business. Some of my father's first residents included Dr. Liebler, Dr. Park, and Dr. Lennox Baker. And all three of them, they were the first 3 or 4 residents at Allegheny in thoracic surgery under his tutelage. And they all went on to have big careers. Dr. Park was with my father for 30 years, as was Dr. Liebler. And Dr. Baker actually formed a company that made a Gore-Tex artificial blood vessel. And go on, next slide. As a consequence of that, he became a multimillionaire, and he donated his money for a chair for the dean of the medical school at Johns Hopkins Hospital, and he named it after his wife and himself. So it just shows you how capable the residents and the surgeons in Allegheny was in the 1960s in performing cardiac and thoracic surgery. So these are actually, is that where this is a log of procedures performed by Dr. Kennett, my father, in the 1950s and 1960s. And these were recorded by their secretary. And her name was Marie Reiser, and she lived somewhere out in Beaver County. And unbeknownst to us, she had kept all of his records, all of Dr. Kent's and my father's records from 1952 until 1970. Dr. Kent died in 1970, so she retired and kept all these records in her attic. And she finally passed away in 2015, and the family called my office and said, "Would you like these records?" And I said, "Well, I'd love to see them." So these next several slides, you can actually see the charges from the surgeons, from the hospital in 1957. So go to the next slide. So these are the charges for something called a right lower lobectomy. So a right lower lobectomy is a removal of the right lower portion of the right lung. And most of thoracic surgery in the 1950s and 1960s was surgery of the lung and the esophagus. The heart was just starting to be an operation that we could do. And as I showed you, the first ones were done 1957, 1958. So the charge to the patient or to the insurance companies was $350. And here are the professional fee schedules in 1957 for removal of an entire lung. That's called a left pneumonectomy. It was $400. And then an aortic valve replacement was $750, and a mitral operation was $500. So those are healthy, strong professional fees. I mean, a surgeon in the 1950s who had a busy practice could do very well. And what's interesting about this is that if you look now, the surgical fee for an aortic valve replacement, if it was $500 in 1957, then like most things, it should be up maybe 10 times what it was then. So it should be $5,000. And in fact, because of Medicare, Highmark, the actual fee to the surgeon is something close to $1,700. And when I started in practice, the surgical fee was $5,000. And over the last 30 or 40 years, the insurance companies have diminished the fee to the surgeon across the board in thoracic surgery by 80%. And as a consequence of that, there aren't any surgeons in Pittsburgh in private practice in cardiothoracic surgery. We're all employed by the hospital because you can't make a living as a heart surgeon on your own, which is pathetic. But that's the status of where we are, particularly with Medicare. So these are the record of expenses for Dr. Kent, including his salary. So in 1958, he was paying himself $10,000 a month, which means he was making $120,000 a year. The average citizen was making $4,000. So he was obviously at the top of the pyramid in Pittsburgh as a professional, making a good salary. Interesting enough, he paid my father $1,500 a month. Now, he was just starting in practice, so that meant he was making close to $15,000 a year, which again was 3 or 4 times as much as the average person. And then all these other charges, his secretary was making $500, so she was making $5,000 a year, which is just about where the average person was situated. Go ahead, next slide. So these next several slides show the actual hospital charges in the 1950s. Okay, go ahead. So you'll see the room charge is $25 a day. The charge for drugs, which would be penicillin or whatever, $28.25. Laboratory, which is a blood drawing, was $24.50. A heart catheterization, this is 1964, so it was $50. An X-ray was $15. An electrocardiogram was $15. And importantly, the telephone was $2. So the total charges for 2 days in the hospital for a heart cath were $185, 1964. All right, go to the next slide. As this is the same material, 1964. Okay, and let's go to the next slide. So these are the charges in 1957 versus 2017, so 60 years later. So the daily room charge has gone from $27 to $2,700. So, you know, if it had gone up 10 times, which is what the salaries have gone up, what cars have gone up, should be $270, but it's $2,700. Pharmacy, $1,400. An emergency room visit, $3,000. If you had to go to the operating room, in 1957 it was $15. It's now $27,000. Just to go to the cardiac cath lab was $180 for the hospital charge. Now it's $23,000. And there were no intensive care units up until the late 1960s, but an intensive care unit is $7,500 a day. But we have made progress. We're not charging for the phone. All right, next slide. So if you look at the number of patients being treated, in 1957 it was 18,000 patients. 60 years later, 25,000. Again, radiology, $50 versus 1,000. Laboratory, $60 versus 2,500. And EKG, $15, $318. And then a CT scan and an echocardiogram were not developed until the 1970s, 1980s. Go ahead, next slide. So again, I want to go back to some of the surgical procedures in the 1950s. And as I'd mentioned previously, the mortality of an open heart procedure in 1958, 40%. So let's go to the next slide. So this is a summary of the operations done on the aortic valve in 1958. There were 18 performed, 9 lived, 9 died, for a mortality rate of 50%. Next slide. And this is a summary of a patient that Dr. Kent had evaluated from Ambridge. She was 33 years of age, married with 2 children, and her husband worked for the Ambridge Steel Company. She'd had rheumatic fever at the age of 8 and had a leaky aortic valve. And she was coming to him for a surgical opinion. And next slide, he says that he doesn't think surgery should be offered. Although it's a new technique, it really hasn't shown to be a proven value, meaning that the mortality was too high. So she comes back in 1961, and she's in worse shape. And Dr. Kent states in his letter that the heart-lung machine is required, and unfortunately, the operation using the heart-lung machine is very high risk. The hospitalization is expensive, and few insurance companies will pay for the operation, which is still true today. So go ahead, next slide. He goes on in the same letter to say that she knows she's in serious trouble, in that she is correct. How much longer she can survive before a catastrophe ensues is unclear. So he's decided to go ahead with the surgery. And next slide. So he and my father proceed with the valve surgery in February of 1962. Next slide. And following the surgery, the heart required multiple bouts of defibrillation, but the heart never resumed a strong enough contraction despite the use of epinephrine and all other types of drug therapy. And after prolonged and repeated efforts, the patient died on the table at 4 o'clock. So this shows you how tough this field was. I mean, he had seen this lady in 1958. He knew he really didn't have the tools to allow her to survive safely in 1958, 1959, 1960. This is 1962. So the next slide. But what was coming along that year was my dad had developed a sutureless valve. And Dr. Kent was involved with some of the development of it as well, but it was really my father's valve. And it was a ball cage design. It was a one-way valve, and he could put it in 10 minutes. And as I mentioned, if you were on the heart-lung machine for more than a half hour, the chances of you weaning from the bypass machine and surviving were slim. So this way, the operation could be performed in 20 minutes. And the operation to replace the aortic valve at Allegheny in 1962 lend itself then to a mortality that went from 40% or 50% down to maybe 5%. So this is the procedure that put Allegheny on the map as a place to come for open heart surgery, particularly for aortic valve surgery. And in the 1960s, again, most patients who were having heart procedures done were having them done because of the complications of having rheumatic fever as a child, and the rheumatic fever affected both the aortic valve and the mitral valve. So this is a picture of the valve. This is how it was put into the heart. Next slide. And next slide. So this is a picture of a rheumatic aortic valve that's diseased. And you can see all those little furuncles within the leaflets themselves. And this is what had to be replaced with the Magovern valve. All right, next slide. Now, those operations required an incision from stem to stern, and with advancements in the last 10 or 20 years, the incision is tiny. Next slide. And for the most part, we're now doing this operation without making an incision at all, and we're taking a valve and crimping it, meaning crushing it so that it sits inside of a catheter. Next slide. Here's the new valve that we're putting in. Next slide. And it's crimped, put inside a catheter, and then placed through the artery in your leg, back up into the aorta, to the aortic valve, and then the sheath is removed and the valve expands and starts functioning right away. Next slide. So here's a picture of this procedure being done today at Allegheny. You can see it's quite complicated, which also explains why the cost of the operating room is so expensive. You know, in 1958, you had a room with basically some clamps, some suture material, and it really wasn't very sophisticated, other than the heart-lung machine. But nowadays, we have an echocardiogram in the operating room. We have CT scans, MRI scans. We've got all sorts of catheter-based therapies, all of which require a lot of monitoring and invasive type radiological help. And this is a good example of it. But we call the length of stay, most patients who had an aortic valve done in the 1970s, 1980s were in the hospital for a week, if not longer. And nowadays, they're going home in 2 to 3 days. All right, next slide. The other operation that Dr. Kent was performing very early on was an operation for an aortic abdominal aneurysm, and that is an aneurysm around your belly button, sitting way in the back. And it's actually the disease that Albert Einstein died of. He had a ruptured abdominal aortic aneurysm. He was treated at Columbia Presbyterian in the late 1950s, and he died. But Dr. Kent was doing this operation with good results in the late 1950s. Next slide. Here's an actual operative note from 1961 of doing an abdominal aneurysm. Next slide. And as I mentioned, if the aneurysm ruptured, then the surgery carried a mortality of 90%. And if it were treated with surgery before it ruptured, it still had a mortality of 30 to 40%. And this operation was first performed in New York City in 1953. But again, Dr. Kent was doing it in the late 1950s as well. All right, next slide. So there's the incision for the operation that was done for decades throughout the country. It went from stem to stern. Next slide. Here's the actual aneurysm on the right, and then the graft to replace the aneurysm on the left through that big incision. Next slide. So nowadays we're able to do the same operation with a stent, and the stent goes through the leg up to the aneurysm, and then it goes inside the aneurysm and it's deployed on either end where the aorta is normal, so that the blood is no longer seeing the aneurysm. Go ahead, next slide. So again, the traditional open operation took 4 hours. This operation takes 2. The Hospital stay was 8 days, now it's 1 or 2 days. People can return to work in 1 or 2 weeks as opposed to 6 to 8 weeks. And the mortality is less than 1%. So it's a huge improvement in a very dangerous operation, which again was being done at Allegheny in the 1950s. Next slide. And I just want to move on to, when most people think of heart surgery, they think of coronary bypass surgery. Coronary bypass surgery, next slide, really was not treated until 1970, either here or in any other city, with other than just words of encouragement. Next slide. Dr. Begg came to Allegheny in 1964, having trained at the Cleveland Clinic, and he was the first cardiologist in Pittsburgh who could do a heart catheterization. And the first heart catheterizations were done at Cleveland in the early 1950s, and Dr. Begg was a Pittsburgh native, went to medical school here, and joined my dad at Allegheny in 1964. Next slide. So you'll go to the next slide. This is actually from Dr. Kent's operative records, a cath report from Dr. Begg in 1964. And at the conference we had in 2017, I gave this catheterization report to his son, Richard Begg, who is a cardiologist at the Butler Medical Center. Next slide. So there was an operation that my dad and Dr. Kent were trying to do in the 60s called a Weinberg procedure, and I won't get into the details of it, but this is a patient who is a 60-year-old steel worker from Wheeling. He had severe blockages, next slide, and undergoes this procedure. And again, at the completion of the operation, cardiac arrest occurred on the table, massage intracardiac epinephrine, next slide, and about 30 minutes after his return to the recovery room, the heart fibrillated, next slide, and in the end we failed, and after 2 hours of resuscitative efforts, the patient died. So this was, again, a very dangerous operation to be performing in the 1960s. Next slide. And these are the number of open heart cases done at Allegheny up until 1970. So it was climbing slowly and steadily, but not a tremendous number of procedures because all these were done for valvular heart disease. Next slide. But beginning in 1970, my father started doing coronary bypass surgery at Allegheny, and it was also being done at other centers in the city. And you can see that each year the number of procedures basically doubles. So by 1996, they were doing 1,600 open heart procedures a year at Allegheny. And it was basically 8 or 9 operations a day. I started in 1985. And the program was extremely busy. There were 9 surgeons operating. We all were doing 2 or 3 cases a day, and we would do 8 cases on Monday, and then there were 8 patients who were coming in for surgery for Tuesday, Wednesday through Friday. It's just very, very busy. All right, next slide. So there's a blockage in a coronary artery as seen by a cath. And the next slide. So nowadays, a lot of these procedures are being done with a stent, so we don't need the open heart procedure to do bypass surgery on many of the patients that were having surgery in the 1980s and 1990s. Next slide. And then the next disease is called mitral valve disease. So this is the other valve in the heart. And again, next slide. The very first treatment of a rheumatic mitral valve problem was a fellow named Charlie Bailey in Philadelphia who actually put his finger through the left atrium, which is a very friable, delicate structure, and opened up the valve with his finger. And it was extremely dangerous. And there really was no backup in the event that there was tremendous bleeding or heart problems. So, next slide. So he's on the cover of Time magazine as well for having done this. It just took tremendous courage. Next slide. But in fact, Dr. Kent was doing this operation in Pittsburgh at the same time. So this is an operative report from 1955 of a mitral commissurotomy. Next slide. And then this same lady comes back 3 years later, and the mitral operation that she had done with Dr. Kent's finger fracture has again closed. But next slide. She then comes for mitral valve surgery in 1958. He does 4 of these operations and 2 dies. There's a mortality of 50%. Next slide. And this lady, again, passes away. And he writes to the referring doctor, "I am still a long way from being reasonably adjusted to the emotional trauma created by the tragic loss of this patient." So that tells you that, you know, Dr. Kent was not going to admit to another surgeon or to the nurses or to the operative team that this had any effect on him, but it did. And it had a big effect on my father as well. They did not take operative mortality easily, and you know, they really had to live with this for years. Next slide. Nowadays, we're doing the same operation with a robotic approach, which has really revolutionized the ability to do the surgery through small incisions. Next slide. And there's the picture of the robot. Next slide. Heart transplantation, next slide. The very first operations were done in 1967 in South Africa. And again, that surgeon was highly celebrated. Next slide. But my father did the first one at Allegheny in 1968, a year later. And then through the years, the Allegheny program has done very well in cardiac transplant. As you can see, we're ranked number 5 in the country in 2016. And we're competing with you know, many big medical centers across the country. Next slide. The other topic that I'll just briefly mention is the artificial heart assist device program at Allegheny. And on the left-hand side, you can see that was a device that I was putting in the late 1980s. And it was terrible. I mean, it was just a huge, clumsy device that did not work well. And nowadays, we have these devices that are the size of your hand, and that field, again, has dramatically improved its results over the past 10 years. All right, next slide. So that's the conclusion. And again, I just want to leave you with the, you know, the final thought that there's been a lot of progress in heart surgery over the past 60 years. We've gone from a mortality rate of close to 50% to somewhere in a range of 1% to 2%. But it's not 0. So as a surgeon, no matter, you know, who the patient was or what the procedure was, you always had to be at the top of your game, because 1% is a big deal if it's you. And so I'm no longer practicing surgery, but I generally, like my dad, would wake up at 4 o'clock in the morning and start thinking about the case, and then, you know, you go to bed at 10:30 or 11, and you call the intensive care unit and you ask them how the patient is doing to make sure you can fall asleep and not have to be called back into the hospital at 2 o'clock. So when people say, well, how are you enjoying your retirement? I tell them that I'm just delighted to be irrelevant. It was a great career, and I'm really proud of what I was able to accomplish, but I'm enjoying being able to sleep at night. Thank you. Yes, sir.
First of all, I'm not really interested in medicine. That was fascinating.
Oh, good.
Excellent presentation. Question is, are they able now to do, I'll call it, for lack of a better term, non-invasive bypasses where they don't crack you open?
It's interesting that we've made huge advances with valvular disease, but not with coronary bypass. We still have to open the chest. If we have to. I mean, you know, the number of patients who need a bypass has gone down 80% in the last 10 or 15 years because of the advances with stenting. And as surgeons, we're delighted with that. I mean, we don't really, that we were doing too many of those procedures 10 or 20 years ago. So the ones that we do now, but they still require a full incision because the suture material is very fine, the arteries are small. Sewing them together requires a lot of attention to detail, and you just can't do that with you can do it with a robot, but it takes 8 hours to do one bypass, which again, that's just too long. Patient can't be on the table that long safely. Yes, ma'am.
With all of these advances, how does medical school change? Like when you went to medical school,
Yeah.
they teach in a different way, or you still learn the same?
Yeah, that's a good question. I think medical education in the first 2 years is probably not that much different. I mean, you have to learn the basics of physiology, pharmacology, pathology, infectious disease, immunology, and all of that information is what you take to the clinical wards. But once you get on the clinical wards, it has changed quite a bit. Some for the best, maybe not for the best in other cases. I mean, I went through, a particularly rigorous training where we would start at the hospital at 6 o'clock, and then we'd stay overnight, take care of the patients, and then have a full day the next day and go home Tuesday night. And then we'd wake up Wednesday and start again and go home Thursday night. So it was what they called every other night training. And the residents would say, well, the only trouble with being on call every other night is you're missing out on half the cases. But, it's just ridiculous. I mean, how many more hours could you spend in the hospital other than that? So they've limited that now to 80 hours that was about 130 hours a week, which is too much. Now it's 80 hours, which is still twice as much as a 40-hour week. But believe it or not, the residents need every bit of those 80 hours to become competent. And so a lot of the residents are taking additional training once they finish because they're really not able to stand on their own 2 feet. And I'm not sure how to, I don't think anybody's going to walk into an operating room and do an operation that they don't think they can do. So, if they can't do it, they're either going to get somebody to help them or take additional training. But that wasn't the case for me. I mean, I came back to Allegheny in 1985, and it was all guns were loaded that this was the son of Dr. Magovern, and could he be any good? So, I had to be able to do these operations without a lot of help right off the bat. Otherwise, it was going to be, mini-me. So it was pretty tough. Yes, sir.
I think you told me you were left-handed.
What's that?
I think you told me you were left-handed.
Yeah.
My father didn't think you could do that.
Yeah. Yeah, actually, I had to learn surgery right-handed, even though I was left-handed. And even to this day, there really aren't any left-handed cardiac surgeons because, if the patient is on the table and you make an incision here, the heart is underneath the left side of the chest. So as a right-handed surgeon, you bring the heart here and you operate with your right hand. If you're doing it with your left hand, the whole thing is awkward, it's upside down. And if you do it left-handed, then you can't do it. I mean, you have to do it right-handed. So, but actually, I got pretty good. I mean, I was, able to use both hands because I could still use my left hand when I needed to. But I did it. Go ahead.
We met in 2007, and you did it left-handed and right-handed. I don't know before you did it, but you did a good job. You said, well, this is going to last maybe 10 years.
Wow.
I was a big guy,
Yeah.
and I'm still here.
There you go. That's very good. Very nice. I'd like to say you look familiar, but I think that would be fake news. Yes, sir.
Did you know we have in our community and church a very, very noted heart doctor in
What's the last name?
McClinic, Dr. McClinic.
McClinic?
Richard, Dennis, what's his name?
Well, William C.
William C. They went by Tick. Tick McClinic.
And was he at Pitt? McClintock?
Yeah, he lived in Ben Avon,
Oh, he lives in Ben Avon.
2 doors up from Dr. Hawk.
Yeah, it's right by
Okay.
Dr. Rock, yeah.
Yeah, he would have been probably my father's, I didn't know him. Okay. Did anybody know Dr. Hawk here?
He was a member of this church.
And my father was very fond of him. He was a very charismatic fellow. And Dr. Evans, where did Dr. Evans live? On Woodland. Okay. Yeah. Well, it's a lovely neighborhood. It really is. And it's a perfect location with the 279 access. You can get all over the city in no time.
You mentioned Dr. Chevalier Quixote Jackson, and
Right.
he lived in Ben Avon on Forest Avenue.
On Forest Avenue.
Yes, and he was also able to use both hands during his procedures.
Yeah. So did Dr. Kent. Dr. Kent was left and right-handed as well. It's interesting. But for the most part, you have to do the surgery right-handed. Same is true with golf. Yes, ma'am.
I'm Amanda Schaefer. I'm from the Sewickley Valley Historical Society. I just wanted to thank Avonworth for hosting you this fantastic presentation. You got a treasure trove of medical history from your dad and his surgeon secretary. As not so much a question, but a comment. I was telling my mom about this presentation, and she paused and said, "Your dad worked on her dad in the 1980s." And he almost didn't let her and her siblings go see them one time after his procedure because it was Halloween and they arrived in their Halloween costumes and they ran into him in the elevator. And he was slightly concerned that they were going to scare his patient. So thank you for the awesome.
Sure. Well, thank you very much for coming. I guess all of us need to get home and watch the Penguins game, right? Thank you. Okay.